Hello, everybody. This is Ken Johnson. I'm with Implant Bite Post. I'm the Director of Marketing here, and just wanted to welcome everybody to our webinar for this month. We'll probably have ongoing webinars coming soon. Next month and probably the month after, we've got a pretty good lineup. So we're excited to kind of talk to you guys tonight about the Implant Bite Post. What we've developed here is pretty exciting. It's a surrogate preparation you can use to get deadly accurate implant records every time. And we'll take the next 45 minutes to kind of present what we've come up with so that you guys can understand what we've developed. I'll be introducing Dene LeBeau, who's our head of product development. We like to call him our chief scientist, and he'll be focused on explaining to you what the Implant Bite Post is and how to use it. And then Dr. Mark Wilhelm, who's one of our customers, has developed a great way to use the Bite Post in a particular case. So from an agenda standpoint, I'll just start sharing my screen so you can see it. Let's see here. Sorry. So from an agenda standpoint, we will again we'll have Dene LeBeau talk about how to use the Implant Bite Post from a dentist standpoint and from a lab standpoint. Dr. Mark Wilhelm will talk about how to use the Implant Bite Post for removable or full mouth cases. There is a troubleshooting section that's also on our website at implantbitepost.com that you can go ahead and take a look at. And then at a later time, but we'll kind of go through kind of some of the 2 or 3 most popular questions and troubleshooting issues that we've encountered. And then we'll have a Q&A at the end. And so from a Q&A standpoint, if you look at your GoToWebinar control panel, everybody should have one up on the right-hand side of their screen. You'll see a section in there for questions. And really throughout the program here, go ahead and type in your questions, and those questions will go to us as presenters, and we'll answer those questions at the end. So without further delay here, I'll start the presentation. I'll hand it over to you, Dean, and you can start your presentation, and then Mark can take over. So here we go. I'm going to hand this over to Dene LeBeau, and he'll take you through part of the presentation.
Thank you, Ken. Appreciate it. We have a really good audience today, and what I'm most excited about is we have a good blend of dentists and technicians, because believe me, we're all involved in this. I'm going to tell you some interesting stories, and let's go to the first. Let me get to the first slide here. Okay. What is it that dental laboratory technicians and dentists have done together since we invented addition reaction silicone for bites? We took those bites off of the preparations. The reason we did it is because it works. What I've always done is I mounted them right to it. You remove all of the tissue, and we're going to go through this a couple of times. You cannot take accurate impressions of tissue. That is for dentures and removable. So when you look at the matrix here, you can see that we cut it back so you can see how the preparation fits and how the tooth fits. No brainer. Case like this, if you had to hand do it, you probably would have followed this where the bite's been open since. Single units, exactly the same thing. We loved it. It works. And we just keep right on using it until all of a sudden we have implants. Well, what happened when we had implants? Because the preparations disappeared, didn't they? So here's a case, a great case that we did, and all we had was an impression off of the opposing and the tissue. And you can see in the upper left screen here where I've had nothing, and then on the lower right where I just measured it twice. I just did this twice. I could come up with these dots every time. So I knew whenever I was making something like this, I was going to have either out of occlusion or it was going to be way too high. That has been common all over the country. So what was the answer? The implant companies, they have been brilliant. They have come up with so many inventions and so many good things, but we still couldn't take a bite. But we had healing caps, even though they barely peek out of the tissue here. So what you have to do was to take an impression over the healing cap, which of course, because it's short and round, needs to have the tissue to support it or it'll wobble. No doubt about that. And the dentist has to send this healing cap with the case for us to have it, but it probably wouldn't work anyway. So what we ended up with, I had bags and bags of healing caps, and you can see in just one kind of implant, there's any remunerations of sizes, lengths, there's just no doubt it's confusing. And after a while, we would be sent a bite, and then I could start screwing in healing caps to try to figure out which one it was, and rarely did it work. Another thing that I started seeing, and this is a very old picture of someone that used to grind cylinders down, and then he would weave floss in between there and take an acrylic bite. Well, I started doing these. Jeff Rouse did some of these. He's out of San Antonio, Texas, and he did it with bite material. It actually worked. But is it reasonable? A lot of time. You make every one of these custom for each time you're in there. Very time consuming and pretty iffy. Usually what you get back in those days when I didn't have any bite posts, I would get back cases like this. Ground. Lots of grinding. Just an absolute nightmare. Or they'd be totally out of occlusion. Sometimes I could fix them, but a lot of times I had to remake them. One day, I had one that was so bad. It was a case that was such an expensive case, a large case. It was a 10-unit case. It was on implants. It was the second time that we had made the case, and this time it was so far out of occlusion we would have to totally redo it. Well, you might know how I felt. But sometimes when you feel that way, you have an epiphany. That day I did. I was angry. Cursing was involved, that's for sure. So I suddenly had this epiphany, and I went to two of my colleagues, and I said, why don't the implant companies just I'll show you. That's how I felt. So I shoved a wax wire down inside the implant, nothing to it, just shoved it in, cut it off to height. Then I started waxing something. I don't know why I waxed exactly what I did. All I was trying to do, you'll see here, is develop an undercut. Nothing to that. Now, there's some luck involved here. I'm going to admit that. And you'll see what it is. So this is basically what I came up with. And I thought, why don't we just make this a surrogate prep? I will put some undercuts in, and that way I won't have thread timing issues because it's all perfectly round. You with me? In the end, this is what it looked like. And I'm going to show you how this thing works. So here it is in wax. I just recreated this, and here it is, if my slide will come up. Here it is in the Implant Bite Post. So let's take a look at this. Let's take a look at how this happens. You can see that how similar they are here. You can see exactly how I did it, but what's more important is how does it work? How does this thing really work? And it's just about as easy as you can believe. So let's take this drawing right here and go to figure number 1. Of course, what you want is you want it fixed. You want something to take the bite that is fixed to the implant. We designed this so the threads would have 3 turns. 3 turns and you're down. And all it does is bottom out. You never use a torque wrench on this, ever. You don't need to. The reason on figure number 2 that I put that 050 standard universal hex head in there is in case it gets a little too snug and you can't get it out with your fingers, you can always go back into the mouth and loosen it. It is not a problem. Number 3, let's go to number 3. That is the undercut. It is round, so it's always where it should be. And it has these sloping sides, which will go down here to 4, and we're going to explain that, is I have 360 degrees of diametric opposition. And what that means is, you see here how it slopes towards the center between the two donuts? You don't have to have it. Like you'll see here, all the material didn't get in. It isn't all in there. It only has to be in a few spots. And always, I'll repeat this, there'll be another repeat. Don't put it underneath the lower donut. It's not necessary. It makes it hard to get out. So number 4 is the diametric opposition. And number 5, that's where we have the laser engraving. Should you get them mixed up, you're using several different kinds of implants and Implant Bite Post. If you get it mixed up, you can go to the website. Automatically you're in. You'll know what they are. So I want everybody to take a look at this case. What this case is these arches oppose each other. On the left side of this mouth, there aren't any teeth to support a bite, even if you wanted to take a wild guess, other than on the upper, this really old failing bridge. So a lot of you would do this one arch at a time. In fact, most of you. And I suspect you'd have trouble on the second arch if you don't have an aid. So here are the Implant Bite Post. They're screwed into both arches. Here they are in the mouth. You can see that they're opposing each other. There's plenty of clearance on these. And here is the bite. This case is Dr. Dan Clater in Colorado. It's a real case for sure. Now we've reduplicated this right on the model. So we screwed them into the model. Remember this, that laboratories, sometimes they don't screw directly in. The hole just needs to be reamed out a little bit. We'll go through that more. Again, when you take a bite and you remove all tissue contact, you know you're accurate, and these two arches with no occlusion on the other side, 0, goes together this ideally. I set this bite just easy, set it, we made it. Here it is right after seating, and it's seated easily. It's actually as good or better than a preparation. There it is from the side immediately afterwards. Now let's talk about the material that you use. You must use a soft, pliable addition reaction silicone. If you use a blue mousse product or a brittle product, you'll have trouble getting it off without breaking it. Jet bite is ideal. I've seen other bites that work. I like this the best. But make sure that it is pliable. Troubleshooting. My bite material breaks or crumbles when removed from the bite registration. We just went over that. So never use the rigid or crumble-prone bite material. There's 2 lengths of bite post. There's a regular length and a long. We cannot make a bite post for the one-off situation. There's always a time that you can't get a bite post in, and I'm going to show you a couple of those where they're so vertically short, there's no reason to make one. I can't screw the bite post in because of the angle of the implant. If the implant is placed too close to the other tooth, well, it might be hard to make a crown too. That's not a problem that the implant bite post caused. Those are placed too close. The lower cylinder of the bite post is held up by soft tissue and will not seat to the implant. Well, obviously that makes it a very deeply placed implant. Try the long bite post, and you might even have to make a small incision or 2 and then screw the regular length post in. Trouble screwing the bite post into the model. We went through that. Sometimes the stone is in the way. There's nothing sacred. You lab guys, there's nothing sacred about that hole. I know most of you know that, but every once in a while somebody calls me on troubleshooting, a lab guy, and tells me the bite post doesn't work because it won't screw in. The implant is so close to the adjacent root the bite post cannot be used. I don't have a solution for that either. It's too close. And a big one is our team has accidentally mixed different bite posts up, the platforms together. So how do we recognize them? Again, go to the IBP identification chart. It's on the website. Very easy to do. There's just a couple of one-off things. This doctor put a bite post on the terminal tooth here, and the excuse me, a bite post there, a bite post here, and then you just used a healing cap here. It would have been better if we put the implant bite post opposing one another, but in this case, it did work out fine. But it's just like, you know, make preps close to each other. Just one more picture of diametric opposition. None of the material got in here, and only a little got in here, and this bite locked in. Now, do you see right here what I was talking about in length? A lot of times there is no vertical length, and there is no bite post I made that can go on this terminal implant. By the way, it's going to be hard to make a crown for that too. It's going to be an extremely short crown. So I just consider that something that I can't do anything about. Here's a case with a very deep implant. There's nothing I can do about that. That's a long. That thing is so deep that you just can't use it. In this case, we used the anterior. It worked out fine. But you'll run into some of those. But almost everything that you use them for, 95% of the time, they work really easily. These are the available platforms that we have, and there are many diameters, and if you go to the website, you'll find out all of those. And we just recently added Megagen, and we don't have the other one on there yet, but I'll probably see it in a moment. So there you have on how it works. And so I'm going to turn this back over to Ken, where he's going to introduce Dr. Mark Wilhelm, who is going to talk about using these for removable full mouth cases and fixed full mouth cases. It's kind of tricky, and a lot of people want to know how to do it, so play close attention, and I'm coming back to you with this now, Ken.
Okay. All right. Thanks, Dean. Okay, Mark, I will make you the presenter, and then you can present your slides.
All righty. Thank you.
Okay, you should be set.
Okay. We're good. All righty. And I'm going to minimize this. I'll move it over here. Well, good evening, everybody, and welcome. And thank you, Dean, for your presentation. I've been using the bite post, implant bite post for, well, quite a while, and since before it even became commercially available. And, you know, there's a lot of things that you can do with them. I've had situations where I've had to trim some or trim an angle off a piece, and, you know, they're inexpensive enough that if I ruin one or two, I can use it for that case and not worry too much about it. So what do we do with we have full arch removable and then fixed implant ones, but a question often comes up for removable, like Dean mentioned, you know, you can't make an impression, or you can make an impression, but you don't want to make a bite record on soft tissue. And you know, it's a good question. And yet, when we do denture prosthetics, complete removable particularly, we still need to get an accurate bite. Getting a good impression will give us a good cast to make a base plate, and then the process base will fit. So you don't have to have a fantastic impression and still have an acceptable, clinically acceptable base. But in the case with denture, still most sore spots are developed from poor occlusion, and they're not typically from a poor fitting base. So, you know, if you're going to error at all, the impression might not be as good, but the bite's got to be good and be repeatable. So in the case of full arch dentures or upper and lower complete dentures, we can do a post-insertion remount, clinical remount, and then equilibrate the dentures. So when our dentures are finished, we get another bite record. We have pre-made index casts, and then just remount the case on an articulator and then fine-tune it in the lab, and then go back to the mouth and then give the dentures to the patient. And we can get some really fine occlusion and virtually eliminate sore spots. But when we come to having implant-supported prostheses, I do a lot of removable, and I do a lot of 2-implant lower denture, overdenture situations. And in that case, I'm relying on a semi-decent ridge with attached tissue, and because the support's coming from the tissue and the bone, and then the retention is coming from the locator attachments. And so those dentures do move, the back end lifts up and they kind of move side to side. So there is some movement. So we need stability in the form of the ridge. But when we have ridges that are extremely lacking, or in the case of an upper where a patient does not like the palate in the denture and we're making a horseshoe type of a denture or a hybrid denture, then essentially we're relying on a bar, and the bar can correct for angle errors and things like that. And then also it makes for a substructure in which we can put a superstructure over, which I'll show you later, and then essentially it becomes a fixed prosthesis. So at that point we really have to nail down our occlusion. So I'm going to run through a complete denture case that we published in Compendium in January 2013, and we just have, in this case, we're showing the final try-in stage, but conventional prosthetics, we would make processed or a base plate and a wax rim, just kind of like normal. And then we'd go to the mouth and we would get our bite record. And in this case, I'm using AluX for the bite record because I want to be able to repeat my bite. So the patient can open and close, open and close, and open and close. And then I can go and check my index in the wax, and we'll see here that we have a single footprint, so that I know that the bite was repeatable. And if it wasn't repeatable, I've got to work on it. And of course, this isn't a denture webinar, but in this case, we're able to get a pretty easy, repeatable bite. And then we would go to the lab and then cut away the front, and then so that our implants are exposed. And then we can go to the mouth, put our implant bite posts in, and then we see here how flat this ridge is. I mean, this is movable tissue. This part moves up over the top of the ridge, so the whole thing moves. And this lady here really was having trouble with her denture. And if we tried to do a 2-implant retained over denture, the denture would move too much and she'd still get sores, and I just know this from experience. So in this case, I told her that she needs more support, so we're going to use 2 more implants and then make a bar, which we'll see later. So the implant bite posts go in the mouth, and then we can reinsert our base, re-register our bite there. It fits into the index, and then now these are rigidly attached to our implant, so then they're not going to be moving. And then we can use our addition silicone, in this case Jet Bite again, to register the bite. I just inject it then up onto the teeth and then onto the bite posts, and making sure not to get too much down there, because like Dean mentioned, these can be really tricky to remove, particularly when we have a lot of bite posts. So then in the end here, we can see that we have a bar that's with my attachments on the end, and this is a design that I like. And then this is a superstructure that fits over this, and then we can tell that this becomes really rigid because it'll sit, this flat part will sit on the bar. We have these grooves to kind of lock it in, and then the attachments to help with retention. And this essentially becomes a fixed prosthesis. And I like this design because this can be removed. Patient can clean this really well. The hybrids are really difficult to clean in the mouth, and actually patients really enjoy this compared to a hybrid. So then when we turn our attention to fixed, like Dean had mentioned, I think attempting a double arch bite at the same time is great for provisionals. And if we're going to go for the final prosthesis, I personally am more comfortable restoring a single arch at a time, and even that is a challenge. So I would do the upper arch, get my incisal edge position and aesthetics all established, the lowers built with provisionals, and then we complete the upper, and then I would turn around and do the lower against something that's already cemented. So in this case here, we're showing a case that Dr. John Kois had presented at a recent symposium, and this was a patient that he had inherited, and there were some aesthetic issues. Regardless, we have some implant issues, soft tissue issues, but we work with what we have sometimes. And so the provisionals were presenting as such. So the occlusion doesn't look too good, and then I want you to notice these stain areas here, because this makes this anterior section removable later for a segmented bite. So then we would take this situation and get diagnostic casts, upper and lower, and mount them with a face bow and a bite, and then we go to the lab and we've got diagnostic casts here showing the upper and the lower kind of in the same condition. So there's in the mouth and then back in the lab. And then with this situation, we can cross-mount cases. So this lower is related to the upper via the face bow and vice versa. So that when we want to mount an upper, let's say that's all we're doing, then we can mount the upper implant case against this lower, and it's without redoing our face bow. So it's cross-referenced. So then in this case, this goes to the mouth. A bite is taken with that provisionals on. And then there's a whole bunch of material injected up into the palate to form an index, because the palate tissue is attached and it's firm and it doesn't move. So relatively speaking, this whole bite as one unit can be indexed back against the palate. And then it goes back into the mouth. So the bite was taken, and then you can take the bite out of the mouth, take the temporaries off, and then remove the abutments, and then place your implant bite post, and then place the index back in the palate. It orients nicely. Have the patient close back into the bite, and then you can inject material around your bite posts, and then you have an accurate bite record against the lower provisionals. And then you could, if that's all you were doing, we'd go to the lab. We see our bite, and this is all indexable against the palate, and here we see our indexes of our bite posts. And then we can go to the lab and mount our upper cast, and then it cross-indexed, so we could go ahead and design the upper and complete it, or then if you were going to do the simultaneous bites for the top and the bottom, then we wouldn't be at this stage. But this is kind of showing us what we can do with that record that we just had. So if we go back to the mouth and we have that same record, then what we would do at this point is, leave this in the mouth, because it's not going to be easily removable, and then the patient can open close at this point, and then we would I would take out, somehow we need to orient for our occlusal vertical dimension. And so to me the easiest part is to remove the anterior section of this and inject against the tissue here to maintain our vertical, and then the patient can open, we can remove the remaining provisional, remove the abutments, place our bite posts, and then inject the material over the bite post. So in this case, Dr. Kois used a different color silicone to kind of make it graphically more visible to see the difference. Otherwise, clinically, we'd likely just use the same material. It'd be hard to demonstrate that in a presentation when it all looks the same. But then you have right here a simultaneous upper-lower. We've maintained vertical, and then it goes right to the lab. And then this is John's facial analyzer, and then from the face bow, and then the case is designed. We have our incisal edge where we want it, and then all the teeth are on this plane, and then the lower is built to the upper, and then the patient's got a new set of provisionals that do meet the aesthetic requirements that we want, and the occlusion's good, and then from there you can go to complete your case. And so that's what I've got here. There's kind of really more elaborate ways to do some of this. We can use Lucia jig type devices that can fit on an abutment and then hold our vertical and things like that. But I wanted to keep things reasonably simple at this point in time. And then if you have questions later, you can jot down this information. Give me an email here or give me a call at my office, and I'd be happy to answer any clinical questions for you. And then at this point, I'd like to turn things back over to Ken. You there, Ken?
Okay, it looks like we've lost.
Yeah, no, I'm here.
Moment, so we're going to.
I'm here, Dean.
Questions. Oh, Ken's back.
Yeah, I'm sorry.
Okay.
I had everybody on mute. Sorry, but thank you, Dr. Wilhelm. So yeah, what we'll do now is just from a Q&A standpoint, I will show my screen here. Hold on just a second while this takes over. So yeah, from a question and answer standpoint, folks on the on that panel, the control panel, you should see a little section that says questions, and you can type your questions in there, and we'll be glad to answer them. In the meantime, if you need any information on the Implant Bite Post, you can go to www.implantbitepost.com. We have lots of material on there. We have videos that you can pretty much see exactly what you saw today, except in a video format. And Dr. Wilhelm is the speaker for that. And you can see exactly how it's used. If you missed the first part of this presentation, if you want to send us an email and ask questions, you can send it to info@implantbitepost.com. And then, like I said, we've on our website, there's lots of information about the product, ordering the product. We have a small e-commerce site, but we also have dealers that have stock available right now. If you want to go ahead and chat with them about getting a few of these available to yourself. So with that, I'll let Dean, if you could just maybe if you've gotten any questions here, maybe you could answer those, please.
Yeah, I have. The first question that I have, which is a really good one, are they reusable? Absolutely, they're reusable. They're made out of titanium, so they can be disinfected and used over and over again. I would also like to say that hopefully in the next year's time, we're going to switch over to a disposable. I think probably in the long run, someone might spend more money using disposables, but it's a good way to get them started. And here's another question that I had already answered. Are they labeled? Yes, each one is labeled as laser engraved, and we have that on the website as well. Oh, and another one came in. This is kind of pertains to what Mark was saying. If I have a multiple unit case, do I need to use every implant fixture for the bite? How many, what location should I use? No, you don't. It's just like a bridge. Let's pretend that you did a traditional ceramic metal bridge for 13 through 15. The dentist would take the bite on 13 and 15 if there was a ponic. Same thing. If you had 13 and 14 and 15, you only need to use 2. So you don't want to get carried away with that. It's unnecessary. And let's see. What about a quantity discount? I'm not sure what that means. We have dealers on the site, and we're open to new dealers, but I want to stay away from being commercial with this. That's something someone could contact us with. But if you go to our website, you'll see the dealers listed on the home page, and we welcome new dealers. I'll leave it at that. Here's one I think we've answered, but I'll try it. Why can't I take bite off the tissue? Again, I would just like to say that the test of time has been that you cannot take accurate bite records off tissue. As Dr. Mark said a little bit ago, sometimes you can get a vertical record off the palate because the phenotype of the tissue is hard and bony, and you can get relatively close there. So if you're going to use a tissue, you're going to have a problem. And I have talked to dental laboratories all over this country as I've presented this, and the people that are using it have great success. And what I think is really makes me feel validated is so many of them, and there's one of you that's listening out there. So many people told me that they have invented something like this, where they've cast it, they've tap and dyed it, and a dentist in a laboratory have been using things like this for years. And the reason I didn't invent it in the first place after I figured it out was because I was sure that every implant company had this on their drawing board because it's just too simple. And by the way, it is that simple. They are really easy to use once you work around the few small things that can go wrong. And this one I think I answered as well. Does the bite material need to engage the lower donut? What if it's below the tissue? If the lower donut is below the tissue, you can't get the bite. You cannot get the material to it. Sometimes, depending on how far it's down there, sometimes you could get some and you might get away with it. I don't pretend that this will fix every implant case out there. It just happens to be perfect for about 95% of them. Any more questions coming in?
Hey, Dean. Yeah, no. Oh, hold on. There's one more question.
Yeah.
So the question is, why not use an impression post?
An impression post like what you use for taking the impression. One, they're probably too long. I can't imagine that working. I'm having even a hard time explaining it. Is Rob on the line?
No, he's.
I can't imagine.
I can help you out there.
Go ahead, Mark. You take that.
Yeah. Well, most of the impression posts are. I mean, it depends on the type of them, but you have the open tray impressions typically have gnarls or undercuts and cross ridges, and they're not meant to be removable. So they lock in, and you can't use that. And then the closed tray impression posts are tapered, and they're meant to be removed from the impression, and then the impression post is removed from the implant and then reinserted into the impression, and then the analog's put on. But the problem with those is they're really tapered and they're thin. So and then you sometimes have a thread timing issue, because they're not round. See, the impression post typically has a flat side or a ball on top or something, some way to index it back into the impression to avoid the thread timing problems. Because if the thread timing, if the implant weren't perfectly perpendicular to the world, let's say, then it could be on an angle like a leaning tower pizza, and then in the lab you screw it in and it's a few degrees off and it's leaning in a different direction. So the index just won't work. It won't sit back on the same way. So what Dean had mentioned earlier in the presentation was that the implant bite post is, well, it's flat on top, and yet the implant could be angled, but it's perfectly round, so that you avoid the thread timing issues, and then therefore you maintain the accuracy.
Okay. We have another.
I got one more here, Ken. I want to get in. Does the doctor need to send the specific bite post or set of bite posts that was used, or can I use a duplicate set in the lab? I felt early on that we always always wanted to have the bite post that was used, and people have been violating. Everybody that we've worked for in my lab uses the bite post, and we have had people not send them in, and we've screwed another one in, and so far everything fits really nice. So preferably, but do I think it's do or die? I guess that I stand corrected. It is not do or die.
Okay. We have another question. Am I correct that these cylindrical bite posts are used only on multiple implant impressions, i.e. not used on a single implant?
Wonderful question. Wonderful question. I know a lot of the people that are online here, and I would just say this. I've been around when we first started getting addition reaction silicone bites, and I used to do a demonstration in my laboratory for dentists that would come to town and see me. I would mount in models that could interdigitate with each other. I would pick the stone off and set them as well as I could, and then I would cut the bite material after I would mount it, and then I would cut the bite up and put the bite in. 99% of the time, it's off a little bit. It is just the way it works. So I have a laboratory policy, a long time policy. I want to bite with every case. I think the implant bite post, if I could only do one thing with it, I want to make sure I could use it for single units. And if anybody disagrees, imagine a terminal molar. You know how that thing, when you're setting them by hand, if anybody tells me that they do this a lot, they're a laboratory technician, they're not thinking about it. Those are almost all single units are going to be high without an accurate bite. So yes, I use them on the singles, always. Do we have any more?
Well, it had a secondary question. Said, the secondary question was, or are they only being used for securing the bite, not for securing an impression? You answered that.
Go ahead, Mark.
I'm not quite sure I understand the question, but we're using these in a bite registration and not so much in an impression situation. The impression, I mean, I always 100% of the time do an open tray impression, so that has an open tray impression coping, which locks into the impression, and then you just unscrew it, and then it stays in the impression. So the bite post, the implant bite post, is used for bite records only.
Okay. Great. Well, that's so far. That's all the questions we have, Dean and team. So I'll let Dean, if you'd like to close this, you can go ahead.
Okay. Well, I thank everybody for attending. If there's any more information or anything I can do, you can call me anytime. My number's on the website. I'll be happy to help you out. We have, again, a lot of dealers on there that have product there, and they're excited to help you get involved. So thank you, everyone, for attending. I appreciate it very much. It was a good afternoon.
Good night, everybody.
Good night, everybody.